I'd like to introduce our first speaker, Dr. Charles Bay. He'll be presenting our Narcolepsy 101 talk, going over the general overview of diagnosis and treatment options in narcolepsy. Dr. Bay is a sleep neurologist who is an associate professor of medicine and neurology at the Perelman School of Medicine in the University of Pennsylvania. He went to Georgetown for medical school and graduated in 1998. He then went on to the Cleveland Clinic for his neurology residency, as well as for his sleep medicine fellowship. He worked at the Cleveland Clinic as an attending for 14 years before moving to Philadelphia in 2017 to work at the University of Pennsylvania. Please welcome Dr. Charles Bay in his Narcolepsy 101 talk.
Hello, my name is Charles Bay, and I am a sleep neurologist. I completed my neurology and sleep medicine training at the Cleveland Clinic and then worked there for 14 years before moving to Philadelphia 3 years ago to work at the University of Pennsylvania. Thank you for the opportunity to speak today at the Narcolepsy Network virtual mini conference. Today, I will talk about Narcolepsy 101, clinical presentation, diagnoses, and management. In terms of epidemiology, for patients with type 1 narcolepsy, meaning narcolepsy with cataplexy, the prevalence is 1 in 2,000. For patients with type 2 narcolepsy or narcolepsy without cataplexy, the true prevalence is unknown. Now, narcolepsy often presents early in life, in the first or second decades of life, meaning as early as grade school through high school, college, and even after joining the workforce. One of the issues is that the diagnosis of narcolepsy can take a long time to make. And it can take 10 years or longer. And there are many reasons for this. One is that there are more common conditions or reasons for a person to be sleepy or even experience unintended muscle loss, muscle weakness. And so that's what led to the delay. But the good news is that with increasing awareness and education, both on the part of patients and also healthcare providers, the time to make a correct diagnosis of narcolepsy is not taking as long. So what else could it be if it's not narcolepsy? One of the most common things is just not getting enough sleep. And so we are a chronically sleep-deprived nation. And so oftentimes just not getting enough sleep, burning the candle at both ends, may be a very plausible reason for daytime sleepiness. Another one would be circadian rhythm sleep disorder. Particularly in children and young adults, it is common for the internal clock to be delayed, and that may contribute to lack of sleep and then also being tired and sleepy through the course of the day, more early in the day than later in the day. Certainly depression is oftentimes considered, especially if someone says that they're sleepy all the time, needing to take naps, so sleeping too much, and then also maybe if there's a component of fatigue. It is important to consider other potential sleep disorders such as sleep apnea or insomnia. If present, they should be diagnosed and treated. Daytime sleepiness, or involuntary loss of muscle tone could be due to a structural lesion in the brain. And so certainly that would need to be considered along with a good neurological examination. And finally, you cannot ignore or overlook potential medication effects, meaning there are many side effects for medications, especially those used for psychiatric reasons, to cause sleepiness or fatigue. Now, this list is, I'm sure, very familiar to this audience in terms of the clinical features of narcolepsy. Now, everyone with narcolepsy should be sleepy to some degree. And the next, for cataplexy, hallucinations, sleep paralysis, not all patients with narcolepsy will have this tetrad, but certainly after being sleepy, it is common for patients to develop cataplexy, even if they may not have it initially. Now, I think focusing on the last point, sleep fragmentation is an important concept. And I think this explains somewhat the reason why patients with narcolepsy, no matter how much they sleep, they remain tired. And that's because the sleep quality is not good due to this phenomenon of sleep fragmentation. Now, in terms of daytime sleepiness, sometimes this can be quite obvious, and sometimes it's not so obvious, even to the person who is affected by daytime sleepiness. So certainly there usually is a complaint of drowsiness or difficulty staying awake. This may be associated with difficulty paying attention. And sometimes this sleepiness can be so severe that it is almost irresistible. That's how some people describe it, which can lead to unintended sleep episodes through the course of the day. Um, and then sometimes too, it may not be as strong, but there can be things such as microsleeps, meaning patients or people can fall asleep very quickly for seconds at a time and not even realize that they fell asleep. This can happen, and in the course of the day, this may result in things such as errors when reading, or also just paying attention to things um, because of this quick lapse in alertness. Also, too, there is something called automatic behaviors. Best example of this is, say, if you're up all night, either studying or then also because you have a third shift, you're driving home, get on the highway, and then the next thing you remember is that you're pulling into your garage. Now, it's hard to know if you actually fell asleep during that time, but it's clear that there's no memory of what happened in between. Now, it could be that the route that you drive is so routine, it's almost like your brain's going on cruise control to get you home safely. However, it's really important to make sure that a person is not falling asleep during those times. And then finally, there is a report or mentioned by patients that they do need to nap throughout the day. Now, cataplexy is more is very interesting, and it is hard to diagnose because there really is no test for it or a good set of questions to really identify cataplexy. Now, there typically is a strong emotional trigger that brings about this loss of muscle tone, and it oftentimes is in the context of laughing at something, laughing very vigorously at something very funny, or when a patient is angry or stressed about something. And it is characterized by this sudden loss of muscle tone that is not appropriate for the context in which it happens. And the important part of cataplexy is that consciousness is preserved, meaning it's not because a person falls asleep and they lose muscle tone, or it's not because you pass out and that's why you end up on the ground, and it's not because you had a seizure, and as part of that you may lose muscle tone, especially recovering from the seizure. Clearly, with cataplexy, the patient describes that they're well aware of what's going on in their environment while they're experiencing this loss of muscle tone. And most often it's not a complete collapse to the ground as you may see in the media or in movies. It's more of a partial loss of muscle tone involving the axial muscles, meaning the knees. Knees may buckle, people may drop things, head may bob, or some people may even experience slurred speech. Now, it is very short lasting, meaning lasting for seconds to minutes. And of interest to the neurologist, that during an episode of cataplexy, you do lose your reflexes and they return once muscle tone comes back. Now, in terms of hallucinations, they can happen as you're falling asleep or waking up and can be visual, auditory, or tactile. And you can imagine that if you were mentioning hallucinations to anybody, especially healthcare providers, the first thing that comes to mind would be some type of psychiatric diagnosis. And so that can also lead to a delay in diagnosis of narcolepsy if these hallucinations are related to narcolepsy. Now, sleep paralysis is a paralysis of skeletal muscles when a person falls asleep or wakes up. During the episode, oftentimes it can be anxiety provoking, even though it's very short lived. To the person in the middle of an episode of sleep paralysis, it can feel like a very long time when they're trying to move or say something and they realize that they can't. It is important to note that sleep paralysis in and of itself can be normal, meaning it can be isolated, or some people may have recurrent episodes of sleep paralysis, without narcolepsy. Now, I just want to touch upon this. You've probably seen similar drawings depicting the different neurotransmitters involved in maintaining wakefulness. And the point of this is just to show the kind of different parts of the brain that are involved with staying awake. And the areas in yellow are the wake promoting areas through monoamine neurotransmitters. When you're awake, these areas are active with diffuse projections through the brain. And this is what it's like in the brain when we're awake and alert. And as you see right in the middle, the white dot, that represents the area in the posterolateral hypothalamus that contain the orexin or hypocretin secreting neurons. And one way to think about this is that when we're awake, the role of orexin or hypocretin is to stabilize the activity of the wake promoting areas in yellow. And so when you're awake, all of these neurons are firing as they should. Now, one way to think about the relationship between being awake and being asleep, can be kind of conceptualized using using a switch, where you have state A and state B. So state A is being awake, as you can see on the top. When we're awake, all the wake promoting areas are firing, and so we're awake. There's also an active inhibition down towards the left, the VLPO, which is one of the sleep centers in the brain. So that's being inhibited. At the same time, you see orexin at the top, and those neurons are acting on the wake promoting areas to make sure that they're doing what they need to. Now, most people don't really know the exact time when they fall asleep. If you think about last night, you probably remember being in bed, being drowsy, and then the next thing you remember is waking up, meaning that at some point you did fall asleep. So once you fall asleep, then you have what's on the bottom. The switch has flipped, and so the sleep on center is active. And so when that is the state. You have inhibition on the wake promoting areas to the right, and also you have inhibition on the posterolateral hypothalamus. So you don't have orexin or hypocretin available to act on those wake promoting areas. Now, for patients with type 1 narcolepsy, what's missing is orexin or hypocretin. That part of the hypothalamus is affected. Oftentimes it's thought to be due to an autoimmune etiology. And so when a person loses orexin, what you then have is you can consider an unstable switch, meaning that you can be awake one moment and then all of a sudden the switch is flipped. So then you feel sleepy and need to sleep the next. And you can imagine, depending on how severe this is, this unstable switch can be very disruptive to someone who needs to, typically be awake and alert throughout most of the day. Now, in terms of the criteria and the International Classification of Sleep Disorders, third edition, type 1 narcolepsy consists of sleepiness with cataplexy and or reduced CSF hypocretin levels. And then type 2 is sleepiness without cataplexy. Now, certainly to make the diagnosis of narcolepsy, a good history is important. And also too, some consider if there's a clear history of cataplexy, as I mentioned, it can be hard to tease out at times. But if you have daytime sleepiness with cataplexy, it's almost, pathognomonic for narcolepsy. However, sleep testing is still important. And so this is where a person would come in for an overnight sleep study to make sure another sleep disorder is not missed, followed by the next day, they would stick around for the MSLT, which is a multiple sleep latency test. It's basically a daytime test consisting of 5 opportunities to take a nap. And in those naps, what we look for basically is, how fast does the person fall asleep? And then also after they fall asleep, do they actually reach REM sleep? Normally in a 20-minute period, REM sleep should not be achieved. And so if, certain criteria are met, specifically if the patient falls asleep on average in less than 8 minutes, and also there are 2 or more sleep onset REM periods, then that would be consistent with narcolepsy. Certainly a good clinical history needs to match. Now, some have ordered genetic testing, and I'll touch upon that in a second. And also, too, what may be better would be to test spinal fluid hypocretin levels. Now, here are some caveats. So the MSLT is a non-specific test, and that also needs to be interpreted in the correct clinical context. And this is because you can have false positive and false negative results. So things that can cause false positive results would be, sleep deprivation, underlying circadian sleep rhythm disorder, and then other conditions, even like untreated sleep apnea, which can disrupt sleep and result in sleepiness. Now, false negative results can be for a variety of reasons, and certainly those relate to more conditions of the study on the day of the test, meaning that if it's noisy, there's construction going on, or if it just so happens that the room is next to the ER, so you have ambulances coming in and out all day long, or if the patient is in pain from either kind of some physical reason or having headaches, then that certainly could prevent that person from falling asleep, resulting in a false negative result. Now, HLA typing generally is, looking for the DQB10602 allele is not as useful, and for this reason. Now, yes, 95% of patients with type 1 narcolepsy are positive for this allele. Now, only 50% of patients with type 2 narcolepsy are positive, and the main issue is that 25% of the normal population, if you were to get this test in them, would be positive for this allele without having narcolepsy. Now, some would say that it may be helpful if it's negative, meaning that it it's one piece of information supporting the fact that the person may not have type 1 narcolepsy, but they still could have type 2 narcolepsy. Now, this is a nice study showing how spinal fluid levels of hypocretin can be helpful. And so what this study, looked at were levels of hypocretin in spinal fluid, patients with narcolepsy divided by whether or not they were positive for the DQB10602 allele and whether or not they had cataplexy. And this was compared to a control population. As you can see here, to the left, the two columns, patients who are HLA positive with or without cataplexy tended to have lower levels of hypocretin in their spinal fluid. Now, to the very far left column, patients with narcolepsy who were HLA positive with cataplexy, they had almost undetectable levels of hypocretin or orexin in the spinal fluid. Compare that to the third and fourth columns, where you had patients with narcolepsy negative for the HLA testing, and also even with or without cataplexy, their levels of CSF hypocretin or orexin were on par with those of the control subjects. So remember, it's very interesting that this small set of neurons, 70,000 hypocretin producing neurons in the posterolateral hypothalamus, is so important for helping us maintain wakefulness and alertness through the course of a day. So the nice thing now is that as of April in 2019, there is a commercially available test through the Mayo Clinic where if you get a spinal fluid sample for a patient, you can send it to them and they can test for the orexin A or hypocretin 1 levels in the spinal fluid. Now, I just like to show this picture because it's actually one of my favorite pictures taken by Lewis Hine in 1930. You probably have seen a similar picture, where the construction workers were eating lunch up on this girder. And so this is certainly not as popular of a picture. Lewis Hine was a sociologist and photographer who at the time was commissioned to document the construction of the Empire State Building. He took pictures of these workers in precarious positions. As you can see, back then there were no safety measures or harnesses while they secured the iron and steel framework of the Empire State Building. And so in order to get these pictures from the best vantage points, he was swung out in this specially designed basket 1,000 feet above Fifth Avenue, just so we can take pictures of these guys working and sleeping and eating. So certainly naps are an important non-pharmacologic treatment for narcolepsy. I mean, first and foremost, it is important to make sure that patients with narcolepsy do get enough sleep. And that also means making sure that sleep hygiene is good to make sure that the total amount of sleep is adequate. Scheduled naps can be helpful. And also, too, as mentioned before, coexisting sleep disorders should be identified and treated. Now, there are plenty of good medications for both the sleepiness and cataplexy that can be associated with narcolepsy. Now, for sleepiness, up until 1999, the mainstay of treatment were just conventional stimulants, amphetamines. So initially, modafinil came on the market as a novel wake-promoting agent soon after armodafinil, and then most recently solriamfetol. And then other novel agents include Xyrem, Xywav, and pitolisant or Wakix. Now, these are very good treatments for sleepiness. If a person were to have type 1 narcolepsy, then certainly cataplexy, depending on how severe it is, would need to be treated. In some instances, cataplexy is very mild, so there's no need for medications. But certainly, if medication is needed, oftentimes antidepressants are used off-label to help manage the cataplexy. But again, the novel agents, Xyrem, Xywav, and now Wakix, which just got FDA approval for cataplexy, can be used to manage not only the cataplexy, but the sleepiness for these patients. In terms of goals of treatment, certainly it's to, decrease sleepiness, decrease episodes of cataplexy in order to maximize function in school and the workplace. Also, to decrease disruption that may be experienced because of the sleepiness and the cataplexy. Meaning, for some patients with narcolepsy, accommodations may be needed at school or at work, consisting of, if it's school, needing extra time or extensions on deadlines to submit projects or papers. At work, it may be helpful to ask for the option to take a nap as needed or to have a safe space to take a nap. And some workers just need to be allowed to come to work late, because many times it's not that they're missing work, but they just can't wake up in time to just get to work on time. So they're late every day by about 10 minutes. And in some workplaces, that can lead to points, which can affect their hireability. The other thing to note often is, because of the sleepiness and the cataplexy, to be aware of potential limitations. Meaning there may be some jobs where even a quick lapse of attention or a microsleep could be detrimental, not only to the job at hand, or even it may be a safety issue like heavy machinery, or if you need to be vigilant and you can't really afford to fall asleep even with optimal treatment. And also too, to be aware that there may be a social stigma, only from the standpoint that some coworkers who are also most likely sleep deprived and don't have narcolepsy find out that Bob has narcolepsy and now has permission to take naps at work or to fall asleep at their desk, and then there starts to be a discussion like, why can't that be me? So it's just to kind of bring that to the forefront as a discussion point, and to make sure that it doesn't lead to further problems. And so I'd just like to say thank you again for the opportunity to speak. And as a sleep medicine specialist, I just find that it's a great time to be in this field, because there are so many treatment options, for patients with narcolepsy that were not available before. And even on the horizon, you've probably heard about other new medications that work on the orexin system. So it really gets at to the heart of what's causing narcolepsy. And so I think the next part is a question and answer session that I look forward to hearing your questions and hopefully answering them. Thank you. Well, thanks for coming today and participating and listening. And I guess I'm starting this meeting off, and there are, let's see, 3 questions so far, so please keep them coming. And what I'm going to do is read the questions and then answer them. So the first question is, can one grow tolerant of provigil modafinil? If so, what recommendations do you have? For example, this person started provigil in 2005 at 100 milligrams once a day. And now they take 200 milligrams twice a day and feel no more in control. And so I think one thing to consider, it could be tolerance, or it could be the narcolepsy getting worse. Now, the good news is that generally narcolepsy doesn't progress like much. I mean, it certainly can. Once a person develops it, it's this persistent difficulty staying awake for long periods of time. And so in the context of this circumstance, if I were to see you in clinic, it'd be a matter of going through a checklist of things to consider as to why might this be happening. So the common things being common is to make sure that you are getting enough sleep. Oftentimes everyone's busy, so chronic partial sleep deprivation can lead to a worsening of symptoms, and even more medication wouldn't be enough to counteract the effect of lack of sleep. The other one is, are there other sleep disorders that may have come up as well? And so certainly things like sleep apnea, if you were to gain weight, and then also too insomnia, this COVID insomnia, you've probably heard about all the stresses related to COVID-19. Many people are experiencing insomnia and also disruptions of regular sleep schedules. The other thing to really look at too is has there been any new medications introduced that may be actually causing drug interactions, which may lead to the less effectiveness of provisional modafinil or armodafinil or any other stimulant used to treat the sleepiness. So once those things are addressed, then it may be time, though, if it is tolerance, to switch medications. And oftentimes what I have some patients do is stay on one medication, consider switching, and then the patients oftentimes figure out what works and what doesn't. And so it may come down to having 2 or 3 options that they're able to take without side effects, with benefit, and then patients can sometimes determine when it is time to switch medications to minimize that tolerance effect. Let's see. The next question is, for someone with narcolepsy on average, what proportion of the nighttime sleep is actually restorative? What is this proportion for people without any sleep disorders or issues? Now, that is a good question. And oftentimes, I think it comes down to how often is the sleep you're experiencing or getting interrupted. So certainly that's the main difference between someone with narcolepsy, with cataplexy versus someone without, in that you do have that element of sleep fragmentation. So for the same 8-hour period, the amount of fragmentation of sleep that occurs in someone with narcolepsy is much higher than someone who does not have narcolepsy. And so you probably read different things about what stages of sleep are restorative. You probably see references to, the percentage of REM sleep and slow wave sleep. And so patients with narcolepsy still get the same amount of those sleep periods, but if you look at the sleep architecture, it's that those, REM periods and slow wave sleep periods are very disrupted and fragmented. And that's the reason why you can sleep 10 hours a day and still be sleepy. Let's see. Next question. Anyone with narcolepsy sleeping 7 or 8 hours does not wake up feeling refreshed. Why then is 7 or hours needed? I think this is a very good point to ask about and talk about, in that, as I just mentioned, anyone with narcolepsy, getting their usual amount of sleep, whatever it is, 7, 8, 9 hours, they still wake up feeling unrefreshed and have sleep attacks through the course of the day. And it still is important for different reasons to make sure you still get that amount of sleep. Now, the average amount of sleep that a person should get varies. You always hear that you need to get 8 hours sleep or 7 hours sleep, and that's an average. So it's a bell curve. And so there are, certainly some people who truly need, 10 hours or more of sleep. They're called long sleepers. So for those individuals, if they were to get 8 hours of sleep, and someone says, "Hey, why are you so sleepy? You're getting 8 hours," it doesn't register. And luckily, it's a very small percentage of the population who are true long sleepers. On the other side of the bell curve, you have people who are actually true short sleepers. They found actually a gene that can runs in families where you have families where they can only sleep for 4 or 5 hours a night, and they're not sleepy in the daytime. And so you have to deal with that. So the one thing to know is, what is your sleep number? How much sleep do you need? And again, for someone with narcolepsy, that can be difficult to determine because no amount of sleep will help you feel rested. But then there are important reasons to make sure that you get enough sleep. One reason is from the metabolic standpoint. There's a lot of good research to show that chronic partial sleep deprivation can affect hormones that affect appetite and weight. And so by virtue of not getting enough sleep, even though it may not be restorative from the alertness standpoint, that may be a contributing factor for either weight gain or difficulty losing weight. So I think it is still important to get whatever amount of sleep that you need. Let's see. The next question is, how close are researchers to treatments that replace orexin hypocretin. And so, so in the pipeline, there are actually some molecules being studied where it doesn't necessarily replace orexin hypocretin, but there are agents that directly work on the hypocretin receptors to activate them, since that is what's missing in those individuals with type 1 narcolepsy. Doesn't mean that it won't be effective for patients with type 2 narcolepsy, since sleepiness, episodic sleepiness is still an issue during the daytime. And so there are actual trials going on for these type of medications and treatments. Next question. I understand that narcolepsy is associated with other psychiatric disorders. Can you speak more about that? So I guess the way I look at it is not that narcolepsy puts you at risk for having other psychiatric disorders, but then depending on the age of onset of symptoms and also how the person looks, then oftentimes there can be, some would call it a misdiagnosis, or just say, hey, something like depression or anxiety or ADD is more common, so that's why let's treat you as such and go from that standpoint. Certainly with patients who have narcolepsy for a long time and it may be refractory, it may be very stress-inducing, anxiety-provoking in that case, and also even in terms of quality of life, may be depressing. And so from that standpoint, I guess you can say that for any chronic medical condition. And so, but I guess based on what we know, it's not that patients with narcolepsy are at higher risk per se, just by virtue of having narcolepsy, to have a psychiatric disorder. Next question. Have you found patients where Xyrem no longer helps, in fact, side effects take hold? Sure, and it could be for different reasons. I've treated a fair amount of patients with Xyrem over the years, and it is nice when you find the right dose and the patients can stay on that regimen for quite a long time. However, things such as tolerance or maybe narcolepsy itself getting worse, that may be the reason why it no longer helps. And then also, one common thing that I've actually had patients tell me is that initially when a person starts on a medication like Xyrem, it's very sedating, and so they have to be in bed before taking it. But then as they continue taking it over time, it's less sedating, meaning they can actually stay up a little bit longer than they're used to. And then also the medication, each dose may be less effective. And so that may decrease the amount of sleep that the person is getting. So that may be part of the reason why Xyrem is less effective over time for some. But in general, I've had many patients successfully take it for quite a long time to treat their narcolepsy. Let's see. So is narcolepsy progressive? I was diagnosed in 1979. I am 77 and I feel I am worse. So as I mentioned before, I think generally it's the good news is that it's not that, narcolepsy doesn't progress per se compared to something like maybe restless leg syndrome, where when it first starts, the symptoms are milder, but then as a person gets older and continues to have the RLS, it can get worse by virtue of the condition. However, since you were diagnosed in 1979, that's quite a long time ago. And there may be other things that are happening which may be affecting your sleep quality, kind of back to that whole question about restorative sleep. And so as long as you're making sure that you get your right amount of sleep, as we get older, there's other physical conditions that can help, even pain. So, and medication, other side effects. So there's a whole host of things that over time can affect sleep quality, which then would result in worsening symptoms in relation to narcolepsy. Let's see. What is the long-term concerns of chronic stimulant use? So in terms of long-term, concerns, depending on the medication that's being used. So for example, like the amphetamines, Ritalin, Dexedrine, those type of medications, you always worry about potential cardiac side effects in the context of, does the patient have other heart diseases, family history of heart disease, and also the amount that's taken to treat the sleepiness. And then in terms of the novel wake-promoting agents, especially modafinil and armodafinil, those have been on the market for quite a long time. And they've been proven to be pretty safe over time. Certainly, they have less potential cardiac side effects, but still need to be taken into account anytime during the course of a person taking it. Let's see. So another question, treatments like Xyrem are really a workaround. How far are we from treatment administration that directly compensate for hypocretin? Let's see. So again, it's pretty similar to a previous question. What other medications are coming up? And as I mentioned, there are in the pipeline medications that are directly working on the hypocretin receptor to activate them. Let's see. Is there an age when you can get cataplexy added to a type 1? Let's see. So let me try to answer that. So certainly anyone with narcolepsy has to be sleepy. So that's usually, certainly the first presenting symptom where an individual is, falling asleep, even after getting 8 hours of sleep, having trouble staying awake. And also that's the reason why they're inattentive or having trouble just struggling getting their tasks done and whatnot. And so it can take years, even for someone with type 1 narcolepsy, to develop cataplexy. So I think if that's the question, then yes, you don't have to have cataplexy right away when you're diagnosed with narcolepsy. And of the other associated features of narcolepsy, oftentimes, cataplexy would be the next common feature to present in those with type 1 narcolepsy. And another question, what is defined as sufficient amount of sleep for type 2? And this is, I guess, there's no specific amount of sleep recommended for type 1 or type 2 narcoleptics. It's just that, it's important to make sure that, for you yourself, how much sleep that you need to get. And it goes back to that bell curve. Again, it may be difficult to discern that, especially if, you get the way you feel after getting 8 hours sleep is the same as if you get 6 hours of sleep. But oftentimes, before the onset of symptoms, there is some indication as to kind of how much sleep you were getting, before that amount of sleep was less restorative or helpful to help maintain wakefulness through the course of the day. Let's see. What is a general difference between provisional modafinil and armodafinil? So they're very similar. I mean, modafinil came out first, and then, both medications work through inhibiting dopamine reuptake and the presynaptic terminus. And one way to think about it is that modafinil has two isomers. There's a shorter acting one and a longer acting one. And then armodafinil is the longer acting one that they isolated and put it into its own pill. And so they're very similar, except for the half-life. And so that's why if you try one and then the other, if that becomes less effective, that's the time to consider one of the newer wake-promoting agents and or trying something like Xyrem. Are there any safety concerns for doing a spinal tap to test for orexin? I am HLA positive for both genes. I am also a down and REM sleeper. Great question, because right now the only way to test for orexin is after getting a spinal tap. And I guess as being a neurologist, I would say that in the hands of a skilled person doing it, it's very safe. And so oftentimes it is helpful to be at an institution where you have someone who does a lot of them, or places where they have spinal tap or lumbar puncture clinics. And so I think the risk of any adverse effects or injury happening is very low in the hands of someone who's skilled. So I would say, if you're thinking about it, ask, like any other procedure, how many times have you done it? And, what are the worst things that have happened? And it's just getting a comfort level with the person who's doing it. And it's also probably a good idea to meet the person who's going to be doing it as well. Let's see. I think I have time for one or two more questions, which just popped up. On narcolepsy and hereditary factors, what is the current evidence as to the extent to which the condition is inherited? And so I think currently, the current thinking is that I think there's certainly like many diseases, genetic predisposition for developing depending on the right environmental trigger. For example, something like Parkinson's disease may run in the family, and until something kind of happens or a person is exposed to something, that's when the disease starts. Similarly, this goes back to the, why does someone develop narcolepsy? A common feature, if you kind of dig back in the history, is that there's some type of infection or kind of viral infection is a common one, like the flu or mono. And, kind of gets back to this autoimmune hypothesis of why a person may get narcolepsy after dealing with one of those viral infections. And it's that as your body's fighting off that infection, the same antibodies that are trying to help in that way are targeting those neurons in the posterolateral hypothalamus, which leads to a decrease in orexin or hypocretin. And so I think that's where you have kind of the tendency and a family history for, increased risk of developing it depending on the environmental exposure. Let's see. And then I'd like to know whether the use of caffeine is recommended. Our son is diagnosed with narcolepsy and he uses medication and drinks a lot of coffee. He also has a lot of anxiety, which may be impacted by caffeine. Let's see. So certainly caffeine is helpful, but most patients with narcolepsy will say that they could probably drink a ton of coffee and still go to bed or fall asleep. And so certainly targeted use of caffeine can be helpful for anybody, not just for those with narcolepsy, just to help maintain periods of wakefulness. Because adenosine is caffeine is an adenosine receptor antagonist. And so the longer we stay awake through the course of the day, adenosine levels increase. So it makes sense why a medication like caffeine can be helpful. And so to your point, yes, if a person is sleepy and that's the reason why they're drinking more coffee, that can provoke and worsen anxiety. So it is important to keep track of how much a person is drinking, and then also balance that with whatever medication they're taking, because maybe they're under medicated or need to be switched to something else. So certainly it's helpful to keep track of that and also talk to his sleep specialist about that before coming up with a plan. It doesn't always have to be eliminated. So my time is up. Thank you again so much for having this time to answer your questions, and I hope you have a good rest of the day.